Hey guys, so welcome to March's Clinical Reasoning Challenge. And this is an interesting one, and it's one that when I treated this patient, I thought it'd be a really good one to share. It's nothing groundbreaking in terms of anything that I want to wow you with, but I think it's very important with these types of patients where they're presenting with a sensation that they're not comfortable with, but yet it's not that serious. So what do we do? Do we let them continue running? Do we stop them running? There's a lot of good stuff and a lot of decision making to be made here. So that's why I was keen to start with this challenge. I'm a big fan of not just talking the talk, but showing you how I actually treat rather than just being a kind of a keyboard warrior, so to speak. So let's get stuck into tonight's challenge. So the first of all, just let me know in the chat that you can hear me. I can see the chat is up. I think you're about 30 seconds behind me tonight, so I can see the chat if you want to ask questions. And don't forget to subscribe if you're watching on YouTube. Don't forget to subscribe to our YouTube channel. I'm going to put a lot more good content on that very shortly as well, so you'll get notified by that. Okay, so my background's professional sport predominantly, and also working in private practice. So these kind of injuries that we're going to see here, I'd be very familiar with these types of injuries where it's a bit 50-50 in terms of is it a tear? Isn't it a tear? Do we crack on? Do we push the patient? But a lot of people, especially my mentorship, it's that bridging the gap from the low level to the high level rehab that need that guidance and support. So with that said, let's get stuck into it. Okay, so a quick recap. This patient, he came in and he's training to do a coast to coast run essentially, but he's doing a lot of triathlon type training at the moment. And what he is doing is he's basically increasing his mileage now to the peak point, where it's just getting to that kind of that peak of his mileage. I think he's up to about or he was up to about 100 miles a week at this point, where he started to break down. So he came in and he was complaining of, he actually texted me on the Saturday morning, and he panicked. He was like, oh, I need to see you. It's I think I've torn my quad. Is there any chance you could see me today here? And the first thing I kind of done with it was like, just calm down. I just said, look, if you want to ice it, if you want to put a bit of compression on it, keep it on stretch over the weekend, and I'll see you on Monday, because I probably wouldn't be able to do anything today anyway for you. So just reassured him with that. And from the mechanism of how it kind of came on gradually, I was pretty confident that that there wasn't too much there. So he came into the clinic. I apologize about the audio. It was a bit echoey, and we'll have that sorted in the next challenge view. And in the subjective assessment, he's had two lateral meniscus injuries a while back in both knees, and his I think it was his right knee was a little bit worse. He was getting a little bit of a pinch in his knee there with over flexion. So when we looked at his objective assessment, toe touch, backward bend, side flexion, rotation, wasn't a whole lot there. Therapists in my mentorship, they'll probably pick up he's not shifted his pelvis maybe over his left foot as much as we probably like him to. But again, nothing major there with that. Good news, small knee bends, lunges, all of them things were paid free. So at this point in the assessment, I'm pretty happy with him. In terms of he settled down after 48 hours, it's a really good sign. And then reverse lunge, where he's going to have to really centrically load these tissues as well. And again, he had absolutely nothing there. So to be honest, by the time we got him onto the bed, I was pretty confident that he was going to be okay. So when we got him on the bed, we done the assessment, the passive assessment, again, it just showed he got a pinch in the back of his right knee with a bit of passive knee flexion. So again, you know, you could argue, okay, is there something up with his right knee here or not? But actually, when we low tolerance tested him, so again, that's my kind of version of, like, I call it coordinative testing. So what we're trying to do here is we're just trying to put some load through the nervous system, see how it tolerates the load. So again, in the literature, it'd be referred to more about kind of force steadiness, where we're just asking the patient to meet our resistance at, you know, roughly at 40 to 50% of your kind of max muscle testing. So it's not a max strength test or anything like that. I just want to know, does he have the proprioceptive ability and the ability to self-organize, to tolerate load, and ultimately contract under isometric conditions? Okay, so that's all we're doing with that test. And all of those directions, I was putting load through up through his soleus, through his hamstring. We put it through his lateral hip, put it through his adductors, and both legs he was tolerating that load pretty well. Okay, so again, with the resisted testing, then that's where, when I was doing the knee flexion testing, that's where I was going for a maximal voluntary contraction in terms of my muscle testing. So the first type of test that I was doing was submaximal. So again, that's more looking at for steadiness. Has he got the ability to match my pressure under submaximal conditions? And again, you know, he's going to need a little bit more proprioceptive input there, and going from the peripheral tissues to the spinal cord, and then that efferent output coming back down again. Has he got the ability to do that? Whereas with the other testing, where I was getting him to resist knee extension, both supine and in prone, I wanted him to ramp up, and I wanted a max voluntary contraction there, because again, I wanted to see, was there any perceived threat to the nervous system, was there any pain experience? And on that occasion, he was good. Prone knee flexion was tight, a little bit of quad stiffness there, if you want to call it that, not lengthening there. So really on the bed, there wasn't that much happening with him. And it was the only thing that really I found with the assessment was that he didn't tolerate load well through his, what I would hypothesize is his internal obliques. So when I brought his knee up to 90 degrees and I asked him to bring his past 90 degrees, I should say, and push that knee towards your opposite rib cage. Again, what I think I'm stressing here is more the frontal plane fibers of internal obliques. I've got an image for that for you in a second, and that was the kind of the only main finding. Okay, so just to go through my thought process, okay, because this is clinical reasoning after all, and thanks for all the people that commented. You know, there was some really good answers, and again, I wouldn't necessarily disagree or anything with anything that was said. I think everyone, it's great that, you know, we could all approach this differently. We'd probably end up in the same place. So just to go through my thought process, okay, so again, when this athlete comes to me, my thought process is, okay, he's getting something there, you know, some discomfort around his vastus medialis, possibly his adductors, that junction there. Okay, what else has to do their work or work with that muscle at that point again? Okay, so that's the first thing I'm looking at. Okay, and again, when I've put some load tolerance through all of these tissues with the testing on the bed, again, there wasn't much that came back at me. Okay, so again, initially I was expecting, I'll be honest, I was expecting him to have an ability to put load through his soleus and his hamstring, but actually that was fine. Okay, so it's like, okay, that's fair enough. So there wasn't too much there in the lower limb for me, really. I was like, okay, you know, there's not really here to go with. But as I said, it was only when I got to this part of the test where we started to put a little bit of load through his obliques here. So again, I bring his knee to 90 degrees, and you can see these frontal plane fibers of his internal obliques here. So again, you know, his iliacus is probably getting involved, but again, when we're bringing the knee past 90, we're going to shorten that distal bit of that. It's going to be a lot harder, obviously, for the rec fem as well to get involved, and the adductors, obviously they will be involved, but we want to shorten all those, and we just want to put a little bit of load through his obliques here. Okay, and again, this is a big one that I see a lot with groin pain and hip impingement and all this as well. So this is something, don't just test it out. You know, people in the mentorship, you're well adverse to this. again, coaching call 4 recently. I talked in depth about the importance of getting load tolerance through here. So this was the big thing that kind of came out where we'd done that 4 steadiness test with him. He wasn't able to match my submaximal resistance on this side compared to the other side. So, and again, he had that history of this niggle where he was telling me it was a psoas, that he felt like there was something up with his psoas, and it's very, very vague. So again, whether it was or not, I've got absolutely no idea. But clinically, this is all I could find. So again, my approach is just, right, let's build it back up and let's give them an ability to tolerate load. So as I said, there was nothing standing out lower limb. When we look at the vastus, what else is it's going to do its job? Okay, so again, this is a good paper by Darn et al. 2012. You could see here the vastus when we're in stance. The quads are taking a lot of load, 4 times body weight. But again, soleus, that's why I was expecting soleus maybe to not be doing its job, which was causing the vastus to overload in stance possibly. But at the submaximal loads there, he was able to tolerate the load there. So again, usually in this instance, I would have seen an inability to tolerate that load at submaximal to start with, but he was absolutely fine on this occasion. Okay, so then we want to start working our way up, and it gets interesting then when we see this. Now again, there's a big limitation there in this paper because it's obviously sprinting. Okay, he wasn't sprinting at the time. He's more of an endurance athlete, so take that with a pinch of salt. But again, this is really, really interesting when we look at the whole body, and you can see the internal obliques where we're hypothesizing that he had an inability to tolerate load. Okay, and again, that's a very, very broad term, and I appreciate that. But when we look at the influence of those internal obliques, and again, we start to look at his injury history on his right side, is that affecting the load tolerance on his right knee? A lot of people said that in the forums, which was great. Okay, but for me, a big thing here, I think, is that lengthening ability of that internal oblique. So again, if I'm thinking he's got some kind of protective response or potential around that oblique, or he's maybe not tolerating as much load as he can, then is that potentially affecting the gait cycle? And again, I have to be careful. We can't really say with any kind of high degree of confidence here that this is absolutely right. Okay, and again, I completely acknowledge that. This is about the clinical reasoning and the thought process. I'm not saying that this is a fact and it was his internal oblique. I'm just telling you what my working hypothesis was at this point of the movement. Okay, so again, that internal oblique, as he pushes off in that stance phase, as his right leg's going through to swing, that internal oblique is going to need to lengthen. Okay, so again, we want that internal oblique to tolerate load both concentrically and eccentrically. And again, there's not going to be a whole lot going through the or movement wise through the rib cage usually with jogging as opposed to other things, but we still want the nervous system to be happy to tolerate load. And again, if it's not, is it causing these adaptations? So again, this is my thought process at this point. Okay, I'm getting interested in that a little bit, and then I'm looking at everything else. Okay, soleus and vasti, again, you can see here extensors. So again, soleus I'm happy with at that point. And again, you're starting to look at iliopsoas there, and you're getting a little bit interested in terms of that's working as essentially an antagonist there with that. Okay, so again, as that hip in stance phase, as that soleus and vasti are extending the knee, that's obviously that iliopsoas is going to be working hard then to have to concentrically contract it. Again, the internal obliques, Jordan Machungi, I think it is his name, I never pronounced his surname correctly. He's obviously talks a lot as well about this anterior tilt and controlling that tilt to the pelvis. And obviously we know the internal obliques are very, very important for that as well. Okay, so again, possibly is there something going on around the pelvis with that internal oblique? Maybe not. Okay, so again, that was my my clinical impression at this point. As he's in his stance phase, obviously it is his body. So as he's pushing off his right leg, or sorry, his left leg, okay, in this instance here, okay, so as he's pushing off, okay, you could see that left external oblique is going to be very interested. Okay, so again, as he's in stance and he's pushing off his left leg, that left external oblique is going to want to tolerate load. Okay, So in regards that, okay, what we're going to need is the internal oblique's ability to lengthen. Okay, so again, the external oblique on the left is going to shorten. The internal oblique on the left is going to have to lengthen. Okay, so this is just a video from Muscle Emotion. Okay, I'm a big fan of looking at this stuff and try to figure things out. Okay, so again, you could see when that oblique, is there another bit here? Sorry, I just took this from my mentorship. Okay, so that internal oblique, okay, it's going to have to lengthen. Okay, so the on the left side. Okay, so we want that external oblique to shorten. Okay, but we want those fibers to be able to lengthen. Okay, so again, for me, the key thing here with this guy is, it's like, you know, what do you do with him? He doesn't have a calf tear, or sorry, quad tear. Like, what do we do now with him? Okay, but he has discomfort. Okay, so all I could find clinically was he wasn't tolerating loads well through the oblique. So that's it. Okay, there's probably some motor adaptations there through various other reasons. That's all I've got to go on. Then let's give his nervous system back an ability to tolerate load. Okay, so that's essentially what we did with the explanation. It's a little bit muffled. I apologize, but hopefully you can hear it. So if you're, I'm going to draw this right. So this is your leg.
Yeah.
This is your body. This is your head. All right. So when this leg is going forward, let's say for example, I was running or you're pushing, your behind your knee or below your knee will go 25 above your leg, so your hamstring, quad, your hip, and then we'll probably put your obliques as well into that. All right. So as you're running, you want to see this oblique's going to work on this the knee drive.
Yeah.
Said another way, if you push this leg off and you're pushing with your left leg, these obliques have to push it that way. Okay, so I'll do another test in a second, I'll just to show you this, but basically when I tested you there, this side was pretty well, but then when I brought your knee up to your chest there and you would go across, that wasn't doing too much work for you there. So I don't think your obliques on that left side is doing a whole lot, which makes sense with all this left-sided stuff that you've got going on. So I think that's just catching up with your loads increase. So I think what's happening is that's not doing a whole lot. So your quad essentially is probably doing 50% instead of that. As your mileage started to increase, it just became a point there in your brain's going, right, I'm happy to do all of this and get through this, but now it's getting to a point where so that pain in your quad, what did that do to change your behavior? And if you stop running, you're giving it a couple of days rest, and now you're getting this thing started. So the pain done its job, but ultimately, in order to get rid of this pain, now as you continue to increase, we just need to get low through your obliques, basically. So the plan for us will be, I'll do a little quick bit of soft tissue through this, but ultimately it's about giving your brain, showing your brain back that it's safe to tolerate load here, basically. So in terms of the tear, I don't think there's any tear there because you're able to push and it's strong and stuff like that. But I think it's a case of anything where you have to use your abs in your quads as you start to increase, it'll probably catch up with you a little bit. So we just want to make sure that we let it go, basically. So we give back your brain, show your brain it's safe to tolerate load here. That means that it'll go down to 25, and then the jobs are good, basically. So, but yeah, overall it's good news, man. Does that kind of make sense?
Yeah, it does make 100%.
And it makes sense with your history of feeling something here. I didn't see about that. So we'll sort that today for you. But I think we get this right, you'll be able to increase the load because symptomatically you're not too bad. I think this is almost like a seesaw at the moment. Your quad is increased tone because your abs are doing less. The more we increase that, the tone and ab will decrease, if that makes sense. So if you pop on your back, I'm sure you'll come perfect. Okay, so again, I apologize. I don't know if you can hear the audio is a bit echoey there. Again, the next few challenges we'll have the audio a little bit better. But all I said to him basically was that, you know, I think that maybe your oblique isn't doing enough here. So I think maybe your quad's having to do a little bit more in that stance. Again, I like using the numbers, keeping it very simple for him, coming down to the patient's level rather than getting really, really fancy. So again, as much as my pain science explanation went into it was, I think your quad's just doing a little bit too much. It's getting a bit grumpy, and it's just saying to your brain, I'm not happy. The pain, it done its job. It stopped you from running. Okay. And now ultimately you're having a couple of days rest and you're getting this sorted. Okay. And again, he had this sensation, this altered sensation, or this unpleasant sensation, if you want to call it that, around his left obliques in his history as well. So again, we just want to give the body back an ability to tolerate load. Okay. So again, for me, symptom wise, let's desensitize these quads. His quads a bit stiff. Yeah. Let's do a little bit of soft tissue on that. But let's spend the majority of our time showing the nervous system that it's safe to tolerate load. God knows why his oblique has lost the ability to tolerate this load at submaximal levels. Okay, but it doesn't really matter. What matters is that we build capacity. We give this person the ability to tolerate load in all directions, essentially, that he needs to be able to tolerate load to be successful. So 80% of our time and attention here, it's actually going to be focused more on his obliques and getting them working well. Okay, so my treatment plan with him at this point is, let's desensitize the symptoms. Okay, I love, like Greg Lavin will say, like settle shit down. Okay, and then let's increase his load tolerance through the obliques. Okay, so again, let's just get some load through here. Let's show his brain that it's safe, and then let's start to integrate the both of them together, because what we need to do then ultimately is we need him to move a thoughtless, fearless movement, in the words of Louis Gifford. So we need him to be able to use that quad and oblique. Okay, so that's going to be my rehab with him at that scenario. Okay, so again, the symptoms. Okay, so all we did a bit of old pin and stretch. Okay, just around the quads, just get those tissues mobilizing. Okay, and as I said, nothing special there. Okay, do it a little bit through his VMO there as well. Okay, again, just hitting those myotendinous junctions, just again, just creating something. God knows what's happening with soft tissue work. Okay, like I'll tell you straight, I'm not breaking up any scar tissue there or anything like that. We're just trying to again, just give it that novel stimulus and get it to settle down. Okay, I'm in between his vastus lateralis and his hamstring there. Again, just improving that quad length. Okay, and then let's spend a bit more time on getting this thing to tolerate load. Okay, so what I really want to do, and again, I can see the likes of Andy, great to have you on live. There's quite a few on the mentorship, and some of you are halfway through the journey. And what I'm drilling into you now is, and this is good for you guys because you haven't unlocked a lot of the case studies yet once you complete the mentorship, but I hate treating something without key performance indicators. Okay, so again, what I don't want to do is, I don't want to treat something ideally unless I could retest something after it. Okay, so I want to establish some
at the moment,
more
so we're completely engaged, basically.
So here I have my KPI of the submaximal load tolerance through his oblique, but ideally I wanted a couple more. Okay, because again, there wasn't a whole lot going on with him. So it was a bit vague. So at least then, if I treat him and I can retest something, am I having an influence on that? Okay, so again, that's my reasoning. I know your keyboard warrior will say, well, how do you know it was this and how do you know it's that? Okay, we have to have something. Okay, so again,
and these obliques, as you push off, this oblique's going to have to really work hard to go that way. So I'm just going to do a couple of tests here. We're going to have a pin in that thing. So just pop your hands up here for me. All I want you to do is I just want you to push your hands this way for me. So you put it right to the right, sorry, yeah. Okay, so if you push.
Okay, so what I'm trying to do is I'm just trying to stress his obliques more, basically. Okay, nothing more, nothing less. I just want to put load through his obliques and see what happens. And again, I'm doing this at submaximal levels at about 50% of my kind of perceived maximal contraction there. Okay, and again, I appreciate that's a bit iffy, but I just want to put some load through to see what happens. Okay, can he meet my pressure? Has he got the proprioceptive awareness to figure it out, to self-organize, and to meet me at the level of force that I have? Okay, so again, he's okay with that, and that actually surprised me, if I was honest, at that point.
And if you push to the right, okay, that's not too bad. So you're not too bad up here. Same again to the right, good, and then to the left. Okay, good. So you can build tension through there, through your proximal obliques. So if you
Okay, so that, I'll be honest, that surprised me at that point. So I was like, okay. So then we just wanted to integrate a little bit of the hips and the lower obliques.
There for me, relax your legs, keep your feet, your knees together. So this will be going this way. So if you push your knees into me, okay, and then if you push your knees that way. Yeah, so can you feel the difference there? Yeah, so you're just kind of noting with your pelvis going this way, basically. So if you just do that once more. Okay, and then go that way. Okay, I can just push it over there, so you feel that. So all that is your brain's not building tension well through here. So when you do this, where do you feel walking?
I feel more,
Yeah.
Yeah.
And when you do it this way, where do you feel it?
I feel like I can engage more here.
Yeah. So it's your hips, because your hips will work when you're doing that, but you can't build tension through your hips into your legs.
Okay, so that kind of makes sense.
This is a good test for us to check after retreat, you know. Yeah. So that once more. Okay. Perfect. Very good.
Okay, so again, with that kind of test there, he will use his hip rotators, of course he will, but he's also going to have to use his obliques. Okay, so again, we just want to ideally see where isn't he building tension well. Okay, so again, what I've done here is that's a KPI. Again, I'm going to desensitize his obliques and then retest them to see basically. Okay, so again, all I did now is I'm just on the kind of where the bone attaches to the tissue again. You know, we're influencing the receptors here, we're influencing skin, fascia. There's a whole host of things that we're doing with our hands-on treatment. Okay, so again, do it in those positions, just helping that internal oblique lengthen. Okay, so when I bring him this way, okay, so his rib cage is going to be then essentially that'll be the same as his rib cage rotating right. Okay, so again, his oblique's going to have to lengthen in this position. Again, if you think about gait, okay, that's going to be kind of your stance phase there. Okay, so again, I'm just trying to lengthen that tissue. And again, like there's a whole host of things we're influencing here, and we have to be really, really careful about what we think we're doing with hands-on treatment. Okay, so again, just stimulating these tissues. Okay, and then I just recheck this KPI.
And then this and push there to there. Good. And then there to there. Okay, bend your knees again, man. Okay, knees together. Your feet right there, and push it with my hands. Good. Once more. Okay, where do you feel that?
So the hip a bit more in the other.
You feel like it's more than the upward. Okay, so have a stand there again and just face this way. And I want to reach your right hand and your right leg again. Okay, good. And then the other side. Okay, and then the other side again. Okay, good. Right, line your back again.
Okay, so the force steadiness improved with this test, which was good, but this one there was still a little bit there, which I wasn't quite happy about. So again, I just wanted to create even more length to that oblique. Okay, so I just added in the upper limb rotation there as well. Okay, so I really wanted to get those tissues to lengthen. Okay, so again, all that skin, fascia, all around that internal oblique, I wanted to facilitate that lengthening there. Okay, so again, just added in that last little bit there of rotation to really get them to lengthen. Okay, so again, we rechecked them again.
Good. And then there to there.
Okay, again, he was able to tolerate load there.
And then push it with my hand. Once more for me. Okay, good. Where do you feel that working?
More here. Still a little bit hippy, but
Yeah, I mean your hips will work.
yeah, because
So you feel your arms are kicking in. Perfect. Okay, so face this.
Okay, and again, he was moving pretty well at that point. Okay, so again, I was happy now that where again, this to me, it's not strength, it's coordination. So again, I'm stimulating there probably his Golgi tendon organs through the myotendinous junction, as well as a whole host of things and influencing just that afferent and efferent input there. Okay, so again, I very much see this more as a coordinative approach as opposed to just strength, because again, how quickly he was able to match my force there or improve his force steadiness, that's not strength. Okay, so that again is a nervous system change, it's coordination. And again, when we can do that first, and then we know that his nervous system's happy to do this at submaximal levels now I can start to ramp him up with confidence. Whereas what I've seen in the past is if we don't have that and we start to increase the load tolerance through those tissues, that's where the motor adaptation literature is very interesting me, where he'll find ways to avoid loading these tissues. And then that's where you'll start to see his maybe his back arch, or he'll take it somewhere else in the body. Okay, so where do we start with his graded exposure? Okay, so in terms of the lower limb, okay, and again, this is a good one for the mentorship therapist listening. Again, his lower limb was good. Okay, so again, his load tolerance in his lower limb was absolutely good. So that meant I could get him to standing straight away and progressing quite quickly, because he had a co-contraction of his knee. He's tolerating load well through his hip. Okay, so again, it's more about his oblique. So that's where then we're able to go straight to that. So if you're watching this on YouTube, just pop a yes. If you're watching this and it's making sense so far, just pop into the chat. The chat's pretty quiet tonight, so feel free if you've got any questions or anything like that. So as I said, if this is making sense so far, just pop a yes and just let me know your biggest takeaways so far, just so that I know I'm not waffling on. Okay, so at this point, what I wanted to do is we're starting his graded exposure here. Now, if he had a quad tear, we'd probably be starting down here and we're starting to work our way up. So again, I'm halfway through my kind of graded exposure system, so to speak, okay, with him. Okay, so the exercises I gave him.
Knee into his hands. You imagine you've got an orange between your fingertips and your knee, slightly under the elbow. I want you to build tension more from the knee to the hand rather than the other way around. Okay? You should feel this upper knee kick in a little bit. Does that make sense? Yeah. Feel that working? Yeah. I want you to hold that for 6 breaths. You can push through your midfoot here as well if you want that. I'll send you these videos through. Yeah. So you get a little bit of hamstring, a little bit of oblique. You feel that? Yeah. You do that 6 times basically. Yeah. So 6 second moments. Yeah. Okay. So start with that 40%. Yeah. So we just want to show your brain it's safe to follow that load. Tuesday, Wednesday, you can start to increase that to 50, 60, 70, 80%. So you can start to ramp it up. Yeah. The first few sets, I just want to do some maximum just to show your brain it's safe to get a little bit load. And then you can tweak it that way a little bit as well with your hip. Yeah. Right. So you're pushing towards your knee. And then I also want you to push straight across towards your groin there as well. Okay? Yeah. The next one I want you to do is you're going to be on your midfoot. So if you have a stand here from this.
Okay, so at this point, all I want to do is I just want to reinforce. So again, we've improved his force steadiness there somehow. Okay, so we want to reinforce that again and again and again, just to give him that coordinative ability to self-organize at these sub-maximal levels. And again, I've got some literature with this. I've spoke to a lot of people about this behind the scenes. I'm nearly clear in my head about all of this stuff. So again, I'm going to put a lot more out about this stuff in the coming weeks and months. But this to me, I think is so undervalued. The importance of the ability to tolerate these loads. Okay, so again, we got that right. Now let's put them up into standing. Okay, so again, this is a small part of the puzzle. Okay, so again, it's so important that we take them through the graded exposure. Okay, so like I don't want you to take away that about the obliques tonight. Okay, but this is just right. Let's get the obliques tolerated load, and then let's get it back into function. Okay, let's get it back into the high level stuff as quickly and as safely as possible. Okay, so now that we had some level of load tolerance through his obliques, we're pretty happy with his load tolerance through his legs anyway. So now let's start to increase it.
Sorry, facing this way. Just come back to touch. Yeah. So left foot forward. Yeah, so get your ribs go forward onto your midfoot. That's it. But don't sink. Yeah. So you'll have a plate over your head basically. This is your plate. So hold on. So this might be a 5 kg to start with. Yeah. Elbow straight. And then I want you to reach as far as you can this way. I want you to have a strong reach with your left hand. I want you to really feel these abs stretch. Yeah. You feel that? Yeah. Or you bang with 20 of those. Okay. So back to the middle of the time. Yeah. That's it. Reach. That's it. So you should feel the stretching around your hip. I'm trying to push hip over there as well. No, just do that. Yeah. You focus on reaching. Your hip should do that if you reach properly. Soft knee. That's it. Don't sink. That's it. Good. Big reach now. And you're just going to do 20 reps of that. Bend that knee a little bit. So see your ribs now, your ribs need to be over your midfoot. That's it, see the difference?
Yeah.
That'll get your quad loading. So I want your quad loading with your abs.
Yeah, got you.
Good man. Good. Okay, so you're going to do 20 reps like that. Then I want the weight out in front of you. Same thing all on the midfoot, now reaching to your left.
This way.
Yeah, good. Okay. So if you have a cable, that's really good as well.
Yeah.
You keep looking straight ahead. That's it. But I want to feel that quad, hamstring, glute all working together. And then you're pushing to have a little bit of resistance there. So see the way your ribs are back behind your knee now? So this is your step in running.
Yeah.
Alright? So go and push it to me. So you should feel that. Keep pushing, push. I'll just give you a little bit. Okay? So you should feel really low there.
Yeah.
So as you snap out of this now, your next step, your right hip's coming through.
Yeah.
See what I mean? So I want you to feel like there's a lot of tension here in your abs.
Yeah.
So when you push, it's your abs that are doing is your legs following.
Yeah.
Rather than at the moment, I think what's happening is your legs doing all the work basically.
Yeah.
I want to get a lot of that in. Does that make sense?
Yeah.
So you could go to, have you got a cable at home or?
Yeah, bands.
Yeah. So we do quite high reps, like 20 to 50 reps of that.
Yeah.
Really feel the tension. So every single rep I want to feel loaded.
Yeah.
Like you're ready to explode.
Yeah.
Alright.
A tempo or is it?
No, just get that tension and then hold it for a couple of seconds and then you can let it go again then. Alright, so you're going to do 2 of those with your isometrics.
Yeah.
And then we'll see you go over next to this, just hammer it with the quad stretches as well.
Yeah.
But I want you to feel like this oblique's taking a lot of work, but I don't want it to get any pain. Does that make sense?
Yeah.
Alright, so we want to show your brain it's safe to take a lot of load through this.
Yeah.
To do those over the next couple of days, when you need you to run again?
On your stage, so like you said, tomorrow run.
Yeah, so I'd give it, keep going with quad stretches tonight.
Okay, so again, the key thing here is his ribs go over his midfoot. Okay, so again, we want everything engaged. So when he does that now, he's soleus, he's got his quads, he's got his hamstring, all interested here. Okay, so again, the difference between him there and here, it's a completely different exercise. Okay, so that ribs over the midfoot, okay, then that's going to be really important for him. Okay, so again, we want that weight just traveling over that midfoot there. That's where his nervous system is going to be interested. Okay, and again, what I'm trying to do here is I'm trying to lengthen those obliques, okay, in the frontal plane here, okay, while he has to react. And again, he's going to feel that loading and that deceleration happen through his internal obliques. So we used a concentric low load isometric on the bed with him to put load through his obliques. Now we're doing the opposite. We're doing an eccentric loading of these tissues. So again, we're stimulating a lot of receptors here. We're stimulating the myotendinous junctions, among many other things. Okay, so again, we just want to use these tissues, show the nervous system it's safe, but I want to use them while his quad, his soleus, everything's doing its job. And then in the transverse plane, okay, in this position here, okay, his external oblique is going to be lengthened. Okay, so again, pre-stretching that. Okay, and then that's going to shorten his internal oblique with this exercise. Okay, so the big thing there that I wanted you to notice, okay, is I asked him when he was running again. Okay, so again, I don't. You want to, how do I say this nicely? You want to have control of this conversation. Okay, so again, I want to see what his expectations were. That's why I asked him when were you going to run again. Okay, and again, you'll have some patients and they will say to you, oh, I'm running again tonight. Okay, so then that's a completely different conversation for me than me telling him what he's going to do or what I think he should do. Okay, so again, he said to me there, well, I was going to wait and see what you said. So he showed me his hand. So now I can guide the conversation. Okay, so I have the power in the conversation there. Whereas if I don't understand what his expectations were with that little question, then you're trying to push your point of view on the patient. Okay, so again, I want to know what his reasoning is. I want to know what his expectations were. So then we can either overcome the objections, or we can we have a little bit of work to do with setting expectations. So with him, he was saying he was obviously going to wait to see what I said, which was great. Okay, so then this is what I said to him.
And those things, smash those 2-3 sets tonight.
Yeah.
See you go tomorrow, and then I'd probably go maybe 4 or 5K tomorrow.
Yeah.
Just really focus on when you're running and what to really use your hands.
Yeah.
So you want to feel tomorrow like these are really moving.
Yeah.
Okay, and then like you feel like they're actually doing something.
Yeah.
Does that make sense?
I think that's the not stigma. I think that's especially longer distance. You don't feel, to use a better word, the need. So like, it's like you see people sprinting it. It's literally here. You kind of running and it's kind of this. There's not a lot going on here.
Yeah, exactly.
I think it's almost like probably fine balance between you relax doing, so you've not got tension all the time, but still allowing.
Yeah, exactly. So you just want to be relaxed. And if you're relaxed, this arm drive you'll get a pre-stretch there.
Yeah.
It won't be maximum like we're going to take in range. But if we get a little bit more range through here, that should hopefully carry through, so we get a bit more movement variability. So you're not just using your quad, you're using this a little bit as well. So I think all that's going to do is do the seesaw. I don't want you to exaggerate it, like you're doing much. But I just want you to be relaxed. And the more relaxed you are, that will go well. The other great thing as well is actually 4 or 5K just nasal breathing. So when you breathe through your nose, you'll feel like this will start to let go a little bit as well. And that'll move around. So see where that goes, and then we'll just start to increase. If you fire the texts tomorrow evening after you do that, see we can start to increase the mileage again. But I think if we can show your brain it's safe to take load through here, get this used to working, then I can send you a couple more stretches if you want as well. In the next couple of days, I'll catch you again, kind of sit down next week if you want. But we'll keep increasing the load. I'll keep sending you the exercise as you go on, because I don't actually think you need soft tissue work. I think you just need a lot of strength for that very good. Cool. Does that kind of make sense? Yeah.
In terms of time frame.
Okay, so I'm going to put a disclaimer here. Physios in the mentorship especially, you need to see him the following week to progress him. Okay, so again, at the moment I'm consulting with a team, so I'm not in Huddersfield a lot at the moment. So again, I was saying to him, I'll chat to you through the text, and again, I've progressed him on myself through videos, which I'm going to show you in a second. Okay, but again, just full disclosure, if I was in Huddersfield that week, I would have saw him again that week. Okay, so again, I just want to put that disclaimer in here. I would have seen him again the following week just to progress him, but again, I'll show you how I did progress him. Other big thing, I don't know if you heard it or not, but nasal breathing. Okay, so that's really, I find that really good with runners. Majority of runners, they, especially with the recovery runs, they run too fast. So forcing them to nasal breathe while they run, it slows them down. And if you try to nasal breathe yourself and you run while nasal breathing, the first few minutes will be a little bit of a shock to your nervous system. But once you figure it out and you self-organize, you'll feel that your rib cage, it melts, and you'll feel the movement happen, and that synchronization, coordination will kick back in again. So you can see I'm big into coordination. I think it's very, very important. And I think it's massively overlooked rather than just strengthening. Okay, so we've given him the nasal breathing, and I've just said, right, 4 or 5 miles, because he was tolerating load well through all these tissues. So again, if he had pain with the resisted testing, then he wouldn't be running. Okay, so just to make that clear.
Also, no restrictions not allowed for long, but I'm hoping to do this early April. That's still a go.
Yeah, but I don't think there's a fair. I think that's just a warning sign. You hit 80, 90 kg or 90 miles, sorry. Your brain's going, I'm on the limit here. So if anything, this is good that it's come on gradually. It's just, it stopped you. It's allowed you to get this sorted. So when you get up to the 100, that's how many miles altogether, is it?
215, so I'm doing 40 hours.
Jesus. So we needed to start this.
I'm saying right now.
Yeah. So I think this is just more of a warning sign rather than a setback. But I think we just need to be smart the next week, build it back up again. And then this is going to be something you're going to need to put into your warm-up. You show your brain how it goes. As I said, you've had a little bit of an issue here. Your brain probably just isn't producing enough force through this part of your body at the moment, and then other things are just getting the job done. Yeah, basically. Does that all that can make sense? Yeah. So as I said, I wouldn't worry about it. I think the next 48 hours, let's see how it responds with just a little bit of this stuff. Yeah. Just get back up running, just relax, nasal breathing tomorrow, 4 or 5K. And let's see where you're at, and we can take it from there. If that's all right. Yeah. Cool. Yeah. All right.
Okay, so there was a good question with Chris there. He just asked if there's patients pain in quads being felt on deceleration from a sprint, are we still looking at the obliques? So would that be more of a lower leg muscle unable to tolerate load appropriately? Yeah. So Chris, that's a great question. I'm actually going to come to that in a second. But that to me, and I have one of these at the moment. I actually put it on Twitter. I don't use Twitter, but I'm going to put some more videos up more now. So I actually put a video of a guy that was getting that with a quad tear, and I've got the exercise on Twitter of what I've done with him, and I actually coach you through it. So have a look at my Twitter account. I think it's, I don't even know the name, but I think it's Davey O'Sullivan or something like that. The Twitter, but that video is up there. That's what I would be using with that guy. But I'll show you here anyway, because in a minute or two, so you kind of beat me to it. Okay, so so the exercises. So I just said, because I was away, just said to him, just show me your exercises. Just send me a quick video. Make sure you're doing them right. Okay, and again at this point here, we want to feel like he's ready to step off that leg. Okay, so that was his first run back. Okay, so he texted me, that was the 9th of Feb. He just said very easy 6K, all nasal breathing, and that was pain free, so I was happy with that. Okay, then we progressed and then over the next couple of days. Okay, I think is that Christy? Yeah, he's doing 215 miles in 48 hours. So yeah, he's got a very Yorkshire accent. Okay. So now, okay, and again, I appreciate he doesn't have to do this, okay, but again, and I know there's a lot of mentorship people watching this, which is great. That's kind of halfway through our kind of like week 6, week 7, but we have to take him to the highest levels of loading and highest speeds of movement as well. Okay, so again, I want to show his nervous system that it's safe and actually tolerate these loads at the highest speeds as well. And I've been caught out a lot with this in the past. Where speed of movement, I think is very, very important as well to give him an opportunity to expose him to these. Okay, so again, this is the progressions I gave him. Okay, so again, just really loading that external oblique. Okay, and then push and rotate. Okay, so again, just trying to get that coordination through with those two tissues. Okay, so again, he's on his midfoot soleus. He's interested. Okay, vastus is there, and then again he's pushing through that midfoot, so again he's going to extend a bit with his hip as well. Okay, so okay, and then we put him in the frontal plane. Okay, so same thing again, just really getting that internal oblique to lengthen and then contract. Okay, because again I want to give him no choice but to tolerate these tissues. Okay, so again, just integrating that in the frontal plane, not the most unorthodox, but he has to lengthen that internal oblique frontal plane fibers there. Okay, and then to contract violently. Okay, so again, I'm hitting it, I'm aiming this at his nervous system rather than strength there. Okay, so again, I want any motor adaptations present. I want to show a system that it's safe to do these exercises and tolerate load. Okay, and he was able to do that. Okay, and then so this was the 13th of Feb, so that was the 9th I saw him, so I must see him on the 8th and 9th, so this is the weekend. Okay, he was able to get back up to the 28 miles. Okay, so again, when what did he say here? So again, I think that was actually a little bit lower than he was able for that week. But again, so he'd done the 6 miles. Then I think we done got him up to 10 miles. Then the next day, and then he was absolutely fine with that. Then we progressed into those exercises, done them before he ran as well as his quad stretches, and he's progressing well there. Okay, so at that point, okay, it doesn't end there. So again, as Christy said there, he's running 250 miles in 48 hours. this is where now we need to build resilience for him. Okay, so it's not just good enough to stop his rehab there. We have to continue to keep increasing that load tolerance for him. Okay, because again, I've just taken him to here now. Okay, but I haven't taken him through the highest levels of load. And this is where the confidence and the resilience is built. Okay, so again, if we look at this paper, and that kind of goes back to your question, Chris, which is good that you've set that up for us. Okay, again, when we look, if he's feeling his quad, okay, when he's decelerating, again, the question I'm asking myself is what else needs to do its job? Okay, so you can see soleus, it's absolutely massive to get that, to help that quad out as well. Okay, so that's where we went next with him. Okay, with his we're into his kind of resilience and his robustness now. Okay, so again, I'm putting his foot on this now because I want to make sure that his soleus does its job. Okay, ideally, I don't like, if I have a choice, I want his foot flat and I want his nervous system to choose his soleus. Okay, but as a starting point progression, okay, I want to make sure and I want to give his nervous system no choice that soleus is doing this job. Okay, so again, a lot of people in the mentorship, you'll see me do the slouches without this. Okay, and again, if we have a choice, remember the motor adaptations literature, if we have a choice to put load away from tissues that we don't want to load, we'll take it. Okay, whereas this is almost a regression where we're giving him no choice but to tolerate load through his soleus. And then a progression will be we take his foot off and he does this without kind of pre-tensing his soleus. Okay, the other options we can do here as well, I was using this with a guy this week as well, is we can vary the ankle. Okay, so again, we can have I know Cal Dietz, triphasic training, he's big into kind of your low ankle, your mid ankle, your high ankle. Again, we can mess with the length tension relationships with these exercises. And again, the slouches here, he should relax his neck here. Okay, when he relaxes his back and he relaxes his neck, there's a lot of load going through that soleus. Okay, and again, if he loses that tension, that heel is coming down and it's going to touch the floor. Okay, and again, his ribs should be over his midfoot. Okay, so I'd like him to be a little bit more forward here, if I'm being honest. Okay, and then you could see that heel, it wants to drop. Okay, so again, and as he pushes, you can see the heel raises. So again, we're getting that soleus interested with his quads, his hips, and everything else. Okay, and then if you go onto my Twitter, you'll see I've done a variation of that exercise for the guy with the deceleration, Chris. So again, just have a look at the Twitter account. You'll see that video this week of the variation I done with him. Okay, so again, we're banging that out. Then the next progression, okay, this is pretty much what I done with the slouch guy. Again, what I'm trying to do here, I'd like his split stance here. Oops, sorry. I'd like that to be the back leg to be a little bit forward. Okay, so I want to challenge his base of support more here, if I'm being honest. Okay, but by lifting his rib cage, okay, we're going to make his quad and soleus do even more work. Okay, so again, if I depress his rib cage, that's going to help his glute do a little bit more. Okay, so if he leaned forward, his glute will be able to do more work. So having to elevate his rib cage, that's going to put more load through his rectus femoris and his soleus. Okay, so again, there's some research out there. It's Pryor et al. Looking at the trunk and the pelvis positions and the reactions that they have to the peripheral limb. And I know Gary Gray's been kind of talking about this stuff for years before that paper. Okay, so again, we want to decelerate. Again, we're just setting them up here so that his soleus is having to do a lot of work. So again, we're kind of now going above and below his injury. Okay, so we've taken care of his oblique. I now want to make sure as well that he can actually tolerate a lot of tension through that soleus. And again, we're starting to wobble here a little bit. So again, that timing of that ability to build tension as his foot hits the floor, okay, that's, you know, where he's probably at the moment. And I can guarantee you, if I brought that plate a little bit closer and I made him when he stepped to actually let his ribs travel forward over his midfoot, you'd see he'd struggle with that even more. Okay, and then the next progression. Okay, so again, we want to see how his ribs don't travel forward over his midfoot. Okay, so that's because the last progression, that's where he's at now with this. Okay, and that's good. So now we're putting load through his rec fem, and we're also putting load through his soleus. Okay, that's a bit better of a rep there. He traveled forward more. Okay, and he's starting to get it there. Okay, so you can see here, there's still these adaptations where he's not confident to really put that load through that soleus. So again, I want to stress his rec fem now, and I have to stress it. You can see he's a little bit far back there. Okay, so again, I want those ribs to travel forward to get that soleus interested. Okay, so the first couple of progressions tonight, I wanted to get that soleus to really do its job. Okay, and as I started to increase the load tolerance through him, okay, then we started to see these other little bits. So again, like for most people, this is absolutely fine, but for him, he has to run 215 miles in 48 hours. So we have to make sure that he can tolerate these loads and that we take him to the highest levels. Okay, so I just texted him today before this. Okay, so again, just wanted to keep it legit. So I just said, how's it going? So he's had some massage and stuff this week, and he's doing the rehab, and he's all good. Okay, so just a little bit of a disclaimer. Okay, so again, with my reasoning here, I'm very conscious. You know, I've got a platform, and I'm telling you what I think is happening, what I think is happening, what is happening. You know, I love this phrase. I think the truth probably lies somewhere in the middle of that. Okay, so again, what I think is happening with my hands and what I'm doing. I'm giving you what I think is happening, but obviously there's still a lot we don't know in regards to manual therapy, the force steadiness stuff. It's, you know, it's evolving. The research it's getting a little bit better with it, but you know, there's so much stuff that from the time I put my fingers on his hands, the information that it goes, that afferent pathway and that efferent pathway, and what happens in between with the spinal cord and noxious stimulus and all this, you know, there's still a lot we don't know. So I just want to make that disclaimer as well tonight, that, you know, I'm not trying to hard sell you here and say, oh, this is definitely happening, because the truth is there's a lot we don't know. Okay, and ultimately there's no new, there's just more clarity from the research to help us implement and take actions. Okay, but what I really want to drive home tonight is that, you know, just because the pain is eased doesn't mean our jobs are done with him. Okay, so again, we have to keep progressing all the way through to the highest levels. Okay, and again, this is interesting because he's going to be taxed physically and emotionally in that run. Okay, so we want to be able to tolerate loads at high speeds and high loads. Okay, both physically and mentally. Okay, so again, you know, we want to really make sure that his soleus can do its job, its vastus can do its job, its oblique can do its job. When he's stressed, he's probably, you know, he's you know, we know from the literature with the rib cage that tends to lose a little bit of mobility. So again, it's important that we keep that range and that he can tolerate this. And again, the nasal breathing to him, I think, is going to be very, very useful as well. For him, as his mileage starts to increase and as he starts to maybe lose focus, I think that's going to be a real nice trigger for him as he starts to go into the dark side with his headspace. Okay, so why I wanted to kick off the clinical reasoning challenges, and again, you know, my intention here is to mix this up a little bit every month, have some like this, have some, you know, very acute cases. Again, you know, I'm not shy about, you know, showing how I treat. I think it's really important, to be honest with you, because I think, you know, there's so many people we're talking in ideals, but actually in the real world, you know, it's not a research paper, it's a person in front of you, and that's where we have to be responsible. We have to take the research, but we have to clinically reason as well. Okay, so again, the hands-on treatment here, okay, that's not, I've got absolutely no doubt that's not going to touch the 215 miles that he has to be able to do. That's where the real life activities and the low tolerance and what he's going to have to go through, it's at a completely different scale. So that's where we have to bridge that gap from the low level rehab to the high level rehab. Okay, and again, we need to take him with our rehab exercises. Okay, we need to create that bit of chaos, and we need to put stress on his body that he's ultimately going to have to be able to tolerate. Okay, and again, this is one of the biggest mistakes I see, that once the pain is eased, it's like, great, you know, you're good to go. Okay, whereas with him, as I said, because I'm working away at the moment, I don't have as much availability, but I made sure that he's progressing. Okay, and again, with those hopping progressions that I've given him, he still has a little bit more to go. I want him to be able to do continuous hops. Okay. And I want that stiffness and that soleus. I want to stress that soleus even more because I want to protect his vastus now. And I want to make sure that the obliques can tolerate load as well. Okay. So ultimately, we need to bridge the gap. Okay. And this is actually a slide from tomorrow. I know there's going to be a few of you guys on the coaching call in the morning. Okay. I actually robbed this slide from that. Okay. Module 7 to 12 in the mentorship. There's a lot of you guys, you're halfway through it now. Okay. Module 7 to 12, that's where you build confidence. That's where we go towards, as Louis Gifford said, thoughtless, fearless movement, where we get the patient to move without conscious control or thinking about it. They're thinking about the actions, okay, or what they're doing or their intent, and we let the nervous system self-organize and figure it out. And that's module 7 to 12 in the mentorship. That's where we have to bridge that gap from the low level to the high level rehab. But you can see, hopefully, the people from the mentorship, you could see modules 1 to 5, where the low level tolerance, the assessments. Hopefully this was useful for you tonight as well. I know you got a couple of other case studies. Got a case study from Shane posted into the forums as well this week. And then once you get to module 12 and we go through these modules, then they'll be more unlocked. Okay. But the big thing here is we need to have everything. We need to use our subjective. We need to be able to have our objective. We need to be able to set expectations and communicate to the patient. We need to be able to design a rehab plan. We need to have our hands-on treatment to be effective. Okay, again, test, retest, use your KPIs. We need to be able to progress and regress as we need to. Then we need to be able to bridge the gap from the high level rehab. Okay, and then we also need to build strength. And again, this guy, I think someone said he's I can't remember who said it. I think he's got, very, very well defined hamstrings. Josh is strong. Okay, he can deadlift, he can RDL, well over 100 kg RDLs. I've seen him do ridiculous amounts. Okay, he's probably squatting and deadlifting, well over like 160, 180, I'd say. Okay, the guy is strong. Okay, so again, that's where we have to bridge that gap, and we have to show the nervous system that it's safe to tolerate load, it's safe to build tension. Okay, and then when we build the tension, then we want to focus on that. So again, the strength of the conditioning is an important part of it, but it's not the only part. The hands-on treatment, it's important, but it's not the only part. Okay, and that's where we need these 8 pillars to be able to bridge that gap from the low level to the high level rehab. Okay, but as always, knowledge is power, but knowledge without action is useless. So again, take action tonight, implement some of this stuff, take what you want, okay, take the good bits and implement it into your step-by-step system, because ultimately for you, it's about having a step-by-step system. And for me there, the nice thing is it's quite a vague presentation. I didn't really know, to be fair, what was going on in terms of, there was no definite, it was very vague, but it was the structure and system that allowed me to go, okay, this is where he's at. There's poor low tolerance through his obliques, and I know he needs to get back to this. So then I used the system to go up through the levels. I knew exactly where to start his rehab at the appropriate level because of the entry level to the graded exposure. He had a co-contraction, so I was happy to go to standing. And then we're starting to increase the load now, and we're about 3/4 of the way up the graded exposure program for him, but he still has little bits to go with. Okay, so as always, if you want help speeding this process up, it's great to have a lot of the mentorship members in tonight. I know a lot of you guys are halfway through this. Christy just said, my dad treated my dad today using this, and he's amazed at how much clearer my treatment plan, how much better he felt with so little hands-on. Exactly. And that's where, I always say this, your patient doesn't want the hands-on treatment. They want how the hands-on treatment makes them feel afterwards. Okay. And again, these exercises, they'll make them feel better because we're moving towards that thoughtless, fearless movement where they increase the confidence. And again, a lot of this stuff, it changes so quickly, it can't be strength. Okay, so for me, it sits more along the coordinative process. Okay, so if you want some help speeding this process up, make sure to get in touch. Go to gotophysio.com/strategy/call. That's how Christy started. That's how I saw Andy was on the call tonight. He's doing some great stuff in the NHS as well. I've seen that there's quite a few others on the call tonight. Chris, So thanks for coming in tonight, and I'll put this up into the members forums as well for you guys. I'll put the full session in as well on clip, so you can watch it from start to finish. All right, so that's it from me tonight. Look out in the next week or two. We'll give you the next challenge, and as I said, we'll change this up every month. I hope you found it useful, and if you want to get your step-by-step system set up, if you want to bridge that gap from the low level to the high level rehab, if you want to use less hands-on treatment, and you want to get really clear on where you're going with your patients and how to set expectations, then make sure you get in touch at thegotofphysio.com/strategy call. All right, so thanks for listening, and I will speak to you at the same time next